for many years we've been asking questions here at LINNC, and it's always been about devices. And one thing that's been absent at LINNC, from maybe some talk about dual antiplatelet therapy, has been talking in depth about drugs, and yet that's been a discussion at this particular meeting. Is something happening there that you suddenly are returning to drugs?
And there's always cycles. I think now we're in the pendulum is swinging more and more towards also intravenous drugs. We've had a few trials that were inconclusive as to whether we should forego giving intravenous TPA or TNK in these patients with large vessel occlusion who present directly to an endovascular center. It's certainly not a slam dunk finding that many of interventionists and in general many of us thought it would not make a difference. It looks like there may be a difference. We still don't have the definitive answers, and I think that the answer will come from subgroups. There probably will be some subgroups where this is not necessarily indicated, in other subgroups where intravenous TPA will be of greater benefit. And that also brings up the question of, look, if we're considering now giving lytics at the end of the case to chase those small, we know that TPA works well for small vessels, right? Would it make more sense to not give the TPA or TNK at the beginning, before thrombectomy, and give it after? So you debulk the clot, the mass, and then what's left, the leftovers, so to speak, you chase with TPA. But at the bigger picture level, my feeling, because you asked me about how we are now and where we are, you know, what we have accomplished incredibly effectively has been the treatment itself, right? So I remember I was doing this procedure 20 years ago. At that time we were using only lytics, or we just started with a Mercy device. We're experimenting with stents in the brain and things like that. And except for stents, which were always very difficult to get up there, these procedure would take 5 hours, right? You would go in the middle of the night at 1 a.m. or something, and you knew it's going to be an all-nighter. And now we go in half an hour, we open the vessel reliably, okay? So I'm honestly less excited, so to speak. I mean, this is an interventional meeting, of course, but I'm less excited about the devices. I still think there's some room for improvement. But that's going to be incremental, because if you look at all the recent registries, we open up these vessels 90% plus of the times, and it takes us half an hour to 45 minutes. How much better are we going to get? And even what is going to be the difference in terms of patients' outcomes if we get better? So we're reaching a plateau, in my opinion. The gains are going to be incremental. But on the other hand, if you look at how long it takes us to move a patient from arrival to the hospital to procedure initiation, we haven't made much progress there. The progress has been much more modest, right? So these kind of workflow systems of care issues, that's where I think we can make huge gains. And to me, where we are heading, perhaps where we should be heading for sure, is simplification of all these paradigms. Less imaging, less intermediate players between the referring emergency physician or ambulance and the interventionalist, right? So simplification of all these paradigms will allow us to treat patients faster and achieve better outcomes. I was very, very excited about the AngioCAD trial that was presented, that was conducted in Barcelona with Dr. Mark Rebo, who is also here at LINNC, that showed us a significant benefit in terms of clinical outcomes when patients go directly to the angio suite and are imaging, are worked up there, so to speak, quickly with a flat panel imaging study, compared to the conventional going through the emergency department type of paradigm. So this is where I think we're going to get the biggest bang for the buck, the biggest gains in our investments. Sure, there's always going to be better devices, okay? But if you think about how the improvement in devices translate into better patient outcomes, it's harder and harder to get to make big gains. We're not going to get the gains that we had when we moved from the Mercy device to the stent reaver. No way. Those are huge changes, right? And they made a difference. They really made a difference in terms of how efficacious this procedure is. So that's kind of how I see the world of the field of thrombectomy moving forward. I think adjunctive therapies are also going to be important, combining neuroprotection with reperfusion, and getting the patients faster to treatment, and that entails better detection, just like we have watches that tell us if we have atrial fibrillation, and probably they're going to tell us if we have a heart attack. I see the time when we're going to have watches or some devices that are going to tell us if we have a stroke, because that's the main problem with stroke. People don't get medical attention in a timely fashion. So these are the kind of things that I think are going to make the biggest impact for the patients in terms of clinical outcomes. At home detection, then from detection to getting the patient to the hospital, and then hospital to procedure initiation. And then there's something that is very important that is emerging now that I'm really excited about, that also involves interventions, but it's a bit of different interventions. There are several approaches that have been shown to be beneficial in recovery. So brain-computer interface, neurostimulation, that were now virtual reality enhanced physical therapy or recovery treatments. So I think we're opening up a big field of neurorecovery after stroke, and it's very exciting.
Yes, well, thank you very much for sharing that with us. And we look forward to hearing where we go next. But it seems like a lot of logistics and a lot of, it's like an orchestra coming together.
Yes, absolutely. And, it's all elements of a chain that all have to be in place for the patients to have the best outcome. It's not just the procedure, it's everything from detection to rehab. And we need to pay a bit more attention to these other elements that are outside of just the thrombectomy procedure.
Even educating society to what it looks like.
No question, yeah.
Thank you very much for being with us.
Thank you.